Yeah. So when you're ready, I can I'll stop whenever you're ready.
Okay, let's do it. I'm ready.
Yeah, but yeah. So this is a male of 39 years old, a highway driver. He used to drive from Highlands to Lane, about 8 hours, 9 hours drive. He had a 5-day history of duck stool, and he came to the consultation clinic. Upon further history taking, he realized that he had a epigastric pain for about a month, and the pain worsened that night and also improved with food intake. He also complained of nausea and fullness of the abdomen, even with some small amount of food. He had no swallowing difficulties, no weight loss, and no other significant medical history. Because he's a driver, he had a chronic lower back ache, and he take aspirin for the back ache. On examination, he's a well-built young man, but he appeared to be anxious because of his condition. His pulse rate was 100 per minute. The vitals were within normal range. He had mild tenderness around the epigastrium, and he had a red, black stool on the rectal bulge upon PR examination. His hemoglobin was 6.5. Our professional diagnosis was duodenal ulcer, a differential of gastric ulcer and clarity. So we admitted the patient, rehydrate the patient, we correct the electrolyte imbalance, and we transfused the patient with 4 units of blood cells, and then we commenced the patient on omeprazole, cimetidine, metronidazole, and amoxicillin. Our plan was to manage this patient conservatively. On day 3, his hemoglobin was 8, temperature was 37.9, pulse rate was 102 per minute. The patient vomited and complained of guarding of the epigastrium when we tried to palpate. We don't have a clear body doctor here, so maybe I can ask Dr. Mike Buin. Are you there?
Yeah, we've got Rodger here as well. Rodger Ikasa from Alotaue.
Okay. So Michael, how would you take it from here based on the
so just based on the history and the exam given there and the investigations, I'll be thinking of a bleeding peptic ulcer, and then with the signs of peritonism there, it's like a perforated peptic ulcer. My initial investigations, apart from what's done already, full blood count and post-match and electrolytes, which I'll probably do imaging. I'll do ask for an erect chest X-ray, confirming the pneumoperitoneum. That would be the additional investigation I'll do, and if that's confirmed, I'll discuss the and go in for a laparotomy and look for the bleeder. But I also have access to gastroscope, so I can have a quick look down with the scope and option of controlling bleeder with local injections of adrenaline around the ulcer. But with peritoneum, I have to go in for the laparotomy and do a washout as well as a repair of the perforation.
Can I just ask, how often does a duodenal ulcer present with both bleeding and perforation?
I think duodenal will be more common because of the bleeding near the blood supply, outside near the blood supply, and so it's more common with a duodenal ulcer than a gastric flare-up.
See, my understanding, correct me if I'm wrong, is that most bleeding from a duodenal ulcer is due to a posterior ulcer that's sort of eroding into the gastroduodenal artery. And they tend to present with bleeding, large volume bleeding, whereas an anterior ulcer, because the anterior part of the duodenum is extra peritoneal, will present with perforation rather than bleeding. And it's a little bit like diverticular disease. It's very rare for a duodenal ulcer to present with both perforation and bleeding. But I might be wrong because I'm not an upper GI surgeon. Do you want to go on, Elvis? We've lost Elvis. We've lost him completely. What do you think, Mike? Have you ever seen a perforated and bleeding duodenal ulcer at the same time?
I've seen one, but it's the one I show is more up within the stomach, not a duodenal one.
Okay.
Yeah.
So I think I'm just going to talk while we're waiting for Elvis. Elvis, when you're back on, just start talking. I think the chest X-ray looking for free gas was a good one.
I'm back on.
Okay. So, yeah, I think you should continue with your presentation.
Yes. Thank you, Michael. I think the choice of our management at the state depends very much on the resources that we have. So I just want to find out how you manage it from your hospital. So I'll continue. So we suspected a perforated duodenal ulcer because of the history. And we did erect chest X-ray, and it shows air under the diaphragm. So based on the resources that we have, we booked the patient for a diagnostic laparoscopy, plus or minus laparoscopic or open omentoplasty. Are you with me, Mike?
Yep.
Yeah, see, Mike said he would go straight to laparotomy.
So that's like
but he also said
that we have.
Yeah, he also said he would do a upper endoscopy. I think if there was no perforation, which I think.
In this case,
Mike, are you at Gizo?
Yeah, I'm at Gizo.
Is the laparoscopic unit there functional, or is it?
Yeah,
okay.
It's functional, but just I haven't had the confidence of doing it on my own as yet.
Okay.
We're supposed to get more help with the visiting
based on the
by the end of COVID.
Hopefully Elvis will give you that confidence tonight. Go, Elvis.
Yes. Yes. So because of the chest X-ray findings with the air under the diaphragm, we know that we will still go for laparotomy. So we will take and put the patient for diagnostic laparoscopy, plus minus laparoscopic omentoplasty, depending on what we saw. So on the laparoscopic findings, there was a perforation, perforation of the duodenum on the anterior part of the anterior aspect of the first part of the duodenum. About the big perforation, we know that perforation less than one centimeter, it's a small perforation. More than 1 millimeter is a big perforation. But this one is a big perforation. So also based on the, there's a lot of criteria that it will determine the outcome of this kind of patient. The age and also these other things like size of the perforation. So based on this, we also found that there were localized spots around the gallbladder area and the liver and in between the duodenum. There was like it was like covered with the fibrous, not strong but more fibrous tissue. So we suck out the localized parts, about 150 mils, and we irrigate with normal saline. First of all, we suck out the insect, all of it inside, and we remove everything. If we want it, and we'll do another water. Because it's localized, it's more easier for us to concentrate the saline around the area. So at it, and also we did
just while Elvis's screen is frozen, I'm intrigued that he was able to close the perforation, because usually, I mean, a 2-3 centimeter hole, it's pretty big. The tissues are all friable, and you know, I would probably not even attempt to close it, but rather
close it with fluorescent test. After we close the perforation, we close, and then we set it with another spectrometer with a tool bag.
So how did you close it? Did you close it sort of horizontally or longitudinally?
So longitudinally, if you do it on the, if you do it along the bowel, along the bowel. If you do it across it with narrow the bowel, you have to do it along the bowel so that you don't narrow the lumen of the bowel. Can you hear me?
Yep. Yeah, so put in the nasogastric tube. It's very simple, but yes, so very vitally important. And the other thing is you want to make sure that the nasogastric tube doesn't come out again, because if it comes out and then someone has to push it back in, they might, you know, they might tamper with your omental patch. So you want to make sure it's really securely fixed to the nose, and there's a few different ways of doing that. You can do a bull ring with an infant catheter. You can just tape it in with a lot of elastoplast. But yeah, just you need to tell the nursing staff afterwards that that nasogastric tube is vitally important, and if it comes out accidentally, it could be really disastrous.
Absolutely. I put it on.
Yep, keep going, Elvis.
I don't know whether I don't know if you have some experience, then they can share their experience with us, how they would have done this case differently.
Well, I was just saying, I'm not sure how much you heard, Elvis, but I was just saying to try and close a 3 centimetre hole before you put the patch on. I don't know, I've never been very good at laparoscopic suturing. I don't think I could technically achieve it. Certainly if you closed it longitudinally, you'd run the risk of causing obstruction, so you want to close it transversely. But I find, you know, if you're going to do an omental patch, you just shove the omentum in the hole and patch the omentum over it. So you put your sutures through and through the sides of the ulcer, and then you push, you mobilize enough omentum sufficient to create a plug, and then you plug that hole with the omentum, and then tie the omental plug over the top, and that avoids having to do any definitive closure. Usually the omentum's already stuck there, and you have to pull it off, make the diagnosis, and then put the omentum back. Alrighty, go for it, Elvis. Keep going.
I didn't hear you. I was out. I just came back in. So, Jerry, so I want to someone to share the experience. Like if the perforation is too big, and then you're not confident with the ability of the bypass.
I've never done one of these before, so I'd consider it, and then I'd be calling someone to help me.
Is there somebody that wants to share their view on this?
But yeah, gastrojejunectomy, where you just bring a loop of jejunum and you use it as a patch to cover the hole. Is that what you mean by gastrojejunectomy?
Oh, you anastomose the jejunum to the stomach. That's your stomach.
Right, but do you make an enterotomy into the jejunum? You actually make an anastomosis. Okay.
Yeah. I would consider that if the findings of the duodenum, if there's by the time you've gone in, there's already some narrowing around the duodenum, and you're worried about the repair.
Yeah, particularly this guy's had weight loss, and you know, it's a big ulcer. You've closed it completely. You just sort of wonder if he's going to be obstructed for a while. So, you know, this is a good example where a gastrojejunectomy makes good sense from a colorectal point of view with no past experience. But I was actually thinking that you were doing like a jejunal patch, but you're not. You're actually doing an anastomosis, a jejunal patch where you bring up a bit of jejunum and plug the hole with a bit of bowel rather than omentum, but you're not.
Yeah. Okay, good, Michael. Thank you, Michael, for sharing your view. I think I have a couple of gastrojejunostomy, but for other things like cancer, cancer in the duodenum, head of the pancreas, but I haven't done it for duodenal ulcer. So, how long do you usually keep the patient, this kind of patient, near the mouth? Rodger is there?
Well, I would just say,
there is only a choice to keep the patient out and reduce it.
I would say something profound like it depends. Presumably you've got a nasogastric tube in, you've got a drain in, an abdominal drain. I would say 10 days, and then I'd probably do a leak test before I took the nasogastric tube out. 7 to 10 days. Probably err on caution and go 10 days. I mean, it's tricky because we have TPN, so we can keep them fasted as long as we like. So you've got to be practical. If TPN's not available, then maybe 7 days.
So Gary, sorry, I missed the conversation. I couldn't hear anything, but what are we talking about?
Okay, so there's a perforated large anterior duodenal ulcer in a PNG Highlander who does a long distance truck haul from PNG Highlands to Lae. He's presented with a hemoglobin of 69. He's had several weeks of melena and he had fullness in the epigastrium. He had a chest x-ray that showed free gas. Elvis took him to theatre. He found fibrinous peritonitis with adhesions and discovered a perforated 3 centimetre anterior duodenal ulcer, which he was able to close primarily laparoscopically with Ovicral and then put an omental patch over. And then he's discussed the possible role of gastrojejunostomy. And the question asked is, if you do a gastrojejunostomy, how long do you keep the patient nil by mouth? Are you muted, Danny? Hang on a sec.
Sorry, can you hear me?
Yep.
Yes. I guess the big thing really is if you reverse the cause of it. So if you give the patient PPIs and you eradicate their H. pylori, because they're most likely going to have H. pylori, stay away from non-steroidals. If the patient's not overly unfit, then you probably would be better off getting onto early nutrition. Because like you said, if you don't have TPN, the thing that's going to lead to breakdown the fastest is if they become severely malnourished. So I don't know how long I would leave it for. I would probably, like you said, I'd do if you could do a follow through on day 7, and then I'd feed them after that.
Yeah, this patient was on aspirin for chronic back pain.
Oh, I see. Okay. But even then, duodenal ulcer is still probably H. pylori, wouldn't it be? Like, I mean, if it's gastric, if it's a pyloric, a pre-pyloric ulcer, then that's related to the non-steroidals. But usually the duodenal ones are still, I would still give them H. pylori eradication on spec just to be on the safe side.
So, I mean, the other thing is you just treat them with Ampgent and Flagyl, which should kill most Helicobacter pylori, shouldn't it? I mean, probably 10 to 15% are resistant. But yeah, I mean, this patient's having a big abdominal operation, so they probably need Ampgent and Flagyl. which should treat their Helicobacter infection. I don't know if you have Clo test available. Mike said he'd do an endoscopy. Clo test is useful for diagnosing Helicobacter. Immediately it turns a yellow colour indicator red, but if you don't have that, you just treat on spec, I think.
Yeah, I have to say I do an endoscopy as my leak test. So at the time of surgery, I'll do a endoscopy and I'll take a biopsy at the same time, just to obviously exclude malignancy and things like that. But that would give you an answer as well. And if it doesn't leak at that stage, you feel much more comfortable.
Yeah, that's the other thing, Elvis. I have a little bit of nervousness about doing a diagnostic laparoscopy in someone with a large duodenal ulcer with melena and a HB of 69, where I'm thinking, you know, could they in fact have an invasive malignancy present? And the problem with laparoscopy, if you haven't done a gastroscopy beforehand, you're not really able to get your fingers in there and feel if there's a cancer. So yeah, you may end up treating a perforated duodenal cancer like it's a duodenal ulcer. That's the one risk, I guess, with not having gastroscopy and doing things laparoscopically.
Hello?
Yep, go for it, Elvis. We've just had Luke Anthony join us. So I think just keep going. Luke, we're just midway through presentation. Elvis is presenting a perforated anterior duodenal ulcer with melena that he's managed to do a laparoscopic omentoplasty on. And he's talked about the possible role. I think he did a loop gastrojejunostomy as well, because he was worried about the integrity of the repair and the possibility of obstruction. And here we are. Go for it, Elvis.
Yes, I think one of the reasons why we choose this approach, management approach, is the age factor. The age is 29 years old. Because more than 35 years old, the prognostic parameter is usually bad for patients. Also, the duration of symptoms, and also the diameter is really big. So that's why we choose to do the bypass. But anyway, I think we have to continue to talk about the other GI problem, which is the upper GI bleeding. It's one of the commonest conditions that we face. I want to know whether this upper GI bleeding is still often in the Solomon Island or
Elvis, you cut out a bit there. So the question was, how common is upper GI bleeding? Is that the question?
Yes. Yes, in the Solomon Island or Vanuatu.
Okay, we've only got PNG, Sunshine Coast, St. George and Gizo here today, and Alotaue, yeah.
So Michael, have you seen of GI bleeding, Michael?
Yeah, I see about 2 to 5 a year. In Honiara would be the same, roughly around less than 5 a year of around about 5 a year of upper GI bleed, and around about half of less than that would be presenting with perforation, but it's sort of increasing with use of homemade alcohol, consumption of the very strong alcohol in young males. We've seen a few coming in after binging with close to 100% alcohol. Wow. Homemade. They probably have underlying gastritis, and then after the binge drinking, develop a perforated ulcer from bleeding and perforated ulcer.
who knows what else is in there? Maybe a bit of battery acid and God knows what else. So we've go Elvis. I think we move on.
Yes. So I think one of the big issues we have, I think, here in Papua New Guinea and I think other countries is the diagnostic investigation, like scopes and all these other things. We don't have them, so it depends on what we have, and it depends on what the upper GI pathology or whatever. I just want to know how from Australia, how you manage this, so we can have some idea about how you manage this kind of case with the upper GI.
Maybe, Rodger, you could answer the question. Just how would you manage a similar presentation of upper GI bleeding?
How do you normally approach this kind of case, well, set up, so we can have some ideas.
In Australia or in PNG?
So we've got some bad reception there, Elvis. We're just going to hear from Rodger. Rodger's going to answer the question how you would deal in Alotaue with GI bleeding.
So for our hospital, we are very limited with resources. We are still working on the endoscopic bit of things. So most of the diagnosis for bleeding, GI bleeding, is done clinically. For duodenal and gastric ulcers, the clinical history taking and examinations, we manage them conservatively. That's when they present with the complications of whether an obstruction or perforation or bleeding. The only way to do a diagnostic, we do a diagnostic extralaparotomy to open up and to see. We don't have any laparoscopic. I'm not well versed. So far in my 1 year, we've seen about 3 cases. They were all elderly. They came with complications of bleeding, obstruction, and perforation. So we lost one that was bleeding due to we didn't have the bloods to sustain it, to take him to theatre at the time. The other that had an obstruction. It felt on extralaparotomy, it felt more like a tumor to me, so I did the bypass, the gastrojejunostomy, side-to-side anastomosis. The patient survived the bowels open, and then we managed with a helicobacter regimen, and the patient got discharged. The other female had underlying medical issues, hypertension and diabetes as well. So whereas she had an obstruction and a bleeding with perforation at the antrum of the stomach, the obstruction all the way to the duodenum. So we did a mental patch, everything, and to be on the safe side, we did a gastrojejunostomy as well. So for our setting, it's very, very difficult to diagnose upper GI bleeding. We don't have the gastroscope or endoscope. Most of our diagnoses are based on clinical, and then we manage the complication.
Yeah, makes it tricky. So what level of diagnostic investigation would you recommend for the Pacific Island countries to have for GI pathologies? Well, I mean, I think endoscopy would be wonderful. That would help exclude an obvious exophytic, ulcerating cancer. That would help perhaps change your management. You might end up doing a distal gastrectomy there. I think it's really hard if you don't have basic upper endoscopy. I think laparoscopy is a luxury, and if you've got laparoscopy, you can do clever things with it. You can do a minimally invasive patch for a duodenal ulcer. I must admit, I've never done a gastro enterotomy for a perforated duodenal ulcer. Usually a patch will do, but a 3 centimetre ulcer is pretty big. I have patched 3 centimetre ulcers before, and they've been fine. They've not leaked. But I think it's really hard to manage upper GI bleeding without gastroscopy. That should be essential. And we've got to make sure that Alotaue gets a gastroscope soon. So Elvis's connection is really bad, so I'm doing the reading for him. We have numerous patients with chronic epigastric pain for years who do not respond to treatment at all. What is your expert advice? Danny, do you want to answer this? Or Luke?
Say it again, Gary.
So we've got numerous, Luke, you might want to answer this. We've got numerous patients with chronic epigastric pain for years who do not respond to treatment at all. I guess he's treating them with an antacid medication or maybe antibiotics. What is your expert advice?
Yeah. That's a tough one. So you have some patients where the pain is more psychosomatic than it is physical. And really what I tend to do is scope them, think significant, and that they don't have cancer, and that, if they get the pain, maybe take some Panadol, try and stay away from non-steroidals. But usually what happens is they stress about it and it makes the pain worse. So it's usually a lot of it is psychology rather than physical. But short of putting them on a PPI and some regular analgesia, I think you just smile at them until they get sick of you and go see someone else. Is that the wrong answer?
No, I don't think so. I think there is a lot of somatoform disease that presents to surgeons or gastroenterologists, and in PNG and the Solomon Islands, you don't have gastroenterologists, so they present to you with their like Danny said, a lot of stress-related and anxiety-related symptoms that present with epigastric pain and chest pain. And once you've done a gastroscopy, maybe even a colonoscopy, you can pretty much reassure them that they haven't got cancer, they haven't got an ulcer, and that they'll survive. So there's a lot of psychology. I feel like I'm half the time a psychiatrist or a psychologist, and the other half a surgeon. Yeah. Go on, Elvis. So what are the recommendations to improve management of upper GI pathologies in the Pacific? I think that's pretty much already been answered. We really need upper endoscopy. Laparoscopy is a luxury. We don't have to have laparoscopy. We can treat Helicobacter on spec, with triple antibiotics. There is resistance, and it's hard to, the treatment in Australia is clarithromycin, amoxicillin, and a proton pump inhibitor for 2 weeks. And if they don't get better, then you just switch the clarithromycin for ciproxin, and if that doesn't work, you switch it for something else. So it's a little bit of guesswork, really. The diagnosis of Helicobacter pylori can be done on histopathology. So you can see the little curvy bacilli. And it's also done on an acid urease Clo test, which turns bright pink if you've got access to that. But if you don't, and they've got a big ulcer, then I think you'd be safe to just treat them on spec as if they have Helicobacter infection, because it's quite prevalent. I don't know the prevalence in the Solomon Islands and PNG, but in Australia it's up to 10 to 15%. In parts of Southeast Asia, Russia is much higher than that. So I think the attitude towards ulcers has changed significantly with the realization that Helicobacter is often the cause. Now, I was just wondering, Elvis, just because your reception's so badly, and we've got Luke who's joined. Luke, would you happen to have any videos or photos of a laparoscopic omentoplasty?
Yeah, I prepared a short talk, but
could you give a really fast version of it? Because we've got about 10 minutes.
How can I put my talk in?
So I can share your screen. You can share your screen if you like. Have you got your laptop with you?
No, I'm not on the laptop. I'm on the tabletop.
Is your talk on that computer?
Yep.
So you can share the screen. I don't know it well enough to talk you through it, but if you go down to the share screen button on the bottom, you should be able to show us your desktop, and then you just open up your PowerPoint presentation or your video. Otherwise, just turn your camera around. So you're videoing from your laptop, from your desktop?
Yes.
Okay.
I think I've lost you.
All right. So we've lost Elvis. Oh, there's Elvis. So Luke's going to try and show us his laparoscopic omentoplasty.
I don't have a video. I purposely didn't have a video of laparoscopic repair, because I don't think it'll help those who especially in those up in New Guinea or elsewhere in the Pacific who have limited access to laparoscopy. I think the teaching would be to be simple, keep it simple, and a mental pad still works. Most of these patients would present very late at night. I've never been able to do this procedure at the best time of the hour. It's usually around 10 or 12 p.m. that they present. And I think the easy way to do it is to do a mini laparotomy. And I think if you can get a small incision from a GFA sternum down to just above the umbilicus, you should be able to deal with that. But laparoscopy, sorry, Gary, I'm just having trouble getting into the screen again.
Okay. All righty. Well, we might have to can that idea. That's a shame. So.
Okay. Radio, I can share now. Oh.
So on the bottom, right on the bottom tab,
Yep.
you should be able to see share screen.
Yeah. I'm pressing it.
And when you now click on a box will open up with your desktop. So just find the document within.
Oh, it's not allowing me. It's not allowing me.
Oh, okay. Alrighty. Yep. All right. Mike, do you have any comments? Any further cases to present?
No, just with the like Lukov said, with us, with the other Pacific Island Council, PNG and Sopas, I'm sure the others as well, is sometimes they most times this patient present late, with the perforated ones, and with us, I think our option would be to make a diagnosis and safely do a laparotomy, wash out, and mental patch. With the recommendations for the way forward, I think what you said is in terms of having endoscopic services in the major hospitals around the Pacific is sort of the way forward in managing upper GI pathologies. We're very fortunate to have facilities here in Gizo, so I'm doing upper and lower GI scopes.
Yep. Elvis, was there anything else on that presentation that we missed out on?
I think we covered most of the things, but I think for the duodenal ulcer, that the prognostic parameters are the age. So this parameter sort of gives you the guide of the outcome of your patient.
Yeah, we've lost you again there.
Age more than 35. The outcome is not really.
Yeah, we're going to have to move on. Elvis, your reception's pretty bad, but yeah, I think Elvis is saying something like high morbidity associated with large delayed presentation of perforated duodenal ulcers. Yeah, sorry about that, Elvis. We're going to have to move on. Reception's just not picking up. Well, that's pretty much it. Thanks everyone for turning up. We've got 5 minutes left. Anyway, Galaxy's just turned up. Don't know who Galaxy is. A71.
Just like to mention, we had analyzed the upper endoscopy data for over a period of 4 years at the National Referral Hospital, and 50% of the clot tests came back positive. So we think that we think that it's around 49%. We think that the incidence is quite higher because this is just the ones that come in for gastroscopy. So we think that there's a high incidence of H. pylori within the community. Therefore, we advocate to treat first with H. pylori, especially those in the clinics and outside the major hospital, and then if the symptoms persist, to have a scope done.
Well, that's incredible. That's interesting. What sort of numbers did you have, Mike, over those 4 years?
It's more than 100, Gary.
Wow, that's serious.
But it started off. This was in analysis from 2014 to about 18, if I can remember.
Yeah.
And it was when we were starting off doing scopes within the NRH. But by the end of the last years, there were more scopes than compared to the initial years.
Yeah, so that's a lot higher than in Australia. Like anecdotally, I would say the positivity for epigastric discomfort who's scoped here in Sydney would be less than 5%.
How is the diagnosis made? Is it you have a clot test or?
Yeah, the clot test. So
What sort of drugs do you give them? Because here we use a proton pump inhibitor, amoxicillin, and clarithromycin. What do you give there?
so we start off with an amoxicillin, metronidazole, and a proton pump inhibitor.
Yeah.
And then if the symptoms persist, then add in clarithromycin.
Right, okay. Because that's kind of the reverse way we do it. We start off with clarithromycin, and then if they're resistant, we go to flagyl and amoxicillin. So, yeah.
Mike, what do you do if they're allergic to penicillin? What do you do if they're allergic to penicillin?
And I will just switch to erythromycin.
Yeah, okay.
Or give one of the cephalosporins.
Yeah. So
Oral.
what I tend to give them clarithromycin and metronidazole and a proton pump inhibitor if they're allergic to penicillin. But I guess you have all those options available to you. Yeah. But it really is the ampicillin that, if they can have that, which makes the difference as far as eradication.
So I'd like to welcome Max, who's just logged in, Galaxy A71. That's Max Pangali from Sopas. You might have to get the full brief from Elvis, who's probably next door to you at the moment. All right. So thanks everyone for attending. Really appreciate it, your effort there, Elvis. Sorry the reception wasn't fantastic, but for the Highlands of PNG, pretty damn good. So thank you everyone, and we'll be in touch in a month.
Thanks everyone. Bye-bye.
Thank you.